Okay, everyone, thanks for coming. It's a privilege to sit together as Kenyans to contemplate on this important issue before us. As you all know, this is a historic time that we're finding ourselves in. COVID-19 is not just a Kenyan issue. As you can see, it's basically a global issue. It's basically mostly in the Northern Hemisphere, as you can see on the map that you should be seeing on your screen. Basically, for those of us that study some of these things a bit more, what is happening is the disease was transmitted across the globe using airlines. And so actually, if you look at these cities across here, they're also the same ones that actually dominate global airline traffic. So it has actually been transmitted across the globe using airlines. And so even on the African continent, any of the big cities that you see that has a big circle is actually a city that has a lot of global connections. Therefore, that is how the disease got into each of these countries. So you can pretty much understand it that the biggest city near you is the one that is going to get it first, and then it will come to a smaller city. We call that hierarchical diffusion from the big cities down to the smaller cities. And the more airline connections you have, the more you are likely to actually have it, which is also the reason why New York is basically very, very big, and Chicago and Los Angeles. So as of earlier today, the US was standing at 1.13 million people sick, 65,000 were dead, 137,000 have recovered. In the case of Kenya, it's 411 sick, 150 have recovered, 21 have died. I did not see very good diaspora data. The only thing I was able to see is that we have lost 21 people in the Kenyan diaspora, but I've not been able to see any data in terms of the number of people that are sick or the number of people that have actually recovered. So obviously, as time goes on, we'll be able to get more and more of these numbers. So maybe I can stop the screen share here for a second. And then also bring up another map real quick, which I wanted to show you as we start. Which is this one here. So if I were to share it also for a second, it can pretty much give us a sense of where we expect most of the Kenyans that are going to be affected to be. So Dr. Kumenda, Texas, as you can see, is going to be very high in terms of number of Kenyans. California is high in terms of number of Kenyans, Minnesota, Seattle, and of course the East Coast, which as you guys already know is significantly affected. So I'm here in Ohio, so likely our numbers are relatively small right now, looking at about 18,000 cases, 1,002 have died, and the numbers are of course serious, but not as high as, for example, the East Coast. I was looking at Dr. Palm's Place, Michigan, 41,000 confirmed, 3,789 dead as of earlier today. And Texas was 28,000 cases confirmed and 782 people dead. Obviously, these numbers are going to be changing with time. So if I can stop the screen share, then I'll be able to come back to the speakers, and then we can see what we can do. So if I can start by introducing the speakers, let me see if I can find Dr. Kumenda here. So Dr. Kumenda is an MD and MPH. He's a board certified physician in family medicine since 2002, currently serving Veterans Hospital, Michael Dibaki Medical Hospital in Houston, Texas. He has served in this capacity for 18 years. He completed his medical school at the University of Nairobi in 1990 and the residency at UTMB Galveston, Texas in 2002. So if there is any other, he has a longer CV, so I'm just gonna stop here, and then if there is more that we need to say, we'll be able to bring it up later. So then we have Dr. Pam Mogaka, PhD in clinical nursing practice. So she does a number of other things, including being a CEO of DIA Awards, which is the Diaspora Entertainment and Recognition Ceremony, as well as other enterprises like Kenya Queens in the USA. And she's also the founder of the Dr. Pam Mogaka show. So she works in a very urgent and busy urgent care, but those are issues that she'll talk about a little bit later. And then, of course, I also mentioned that we have the privilege of having Dr. John Ngugi and Jane Ngugi as well. So Jane Ngugi is also a clinical nurse practitioner, and Dr. Ngugi is an MD. So both of them will come in with time. So Jane and John are here in Ohio with me. Pam is up north in Michigan, and Dr. Kumenda is the one that is a little bit further south from us. So we will have the opportunity for each of these speakers to say something about themselves as we begin. So I guess by way of beginning, Dr. Kumenda, I'm going to come to you first, and maybe you can start by telling us something small about what is happening in Texas. And we can make it maybe a minute or two introduction here, then we begin rolling down some of the other topics I've listed. Thank you. Dr. Kumenda.
Thank you. I'm grateful to have been invited to join you for this kind of conference. And I'm glad that we now have the technology that enables us to coordinate, even whether you're in Texas, you're in the south, you're in the east, in the west. Technology is bringing us very close. And we are meeting at a time when obviously we have challenges. These challenges not only are affecting Americans, but also affecting now most of us, especially those of us who are immigrants who came here. And we decided that the best careers to choose are the medical careers. Mm-hmm. I know that most of the Kenyans in Texas whom have been aware have either tested positive or have symptoms or clinical symptoms which suggest that they may have COVID-19 are all either working in the healthcare field or people who are kind of working in an emergency responders. So we do have challenges, and I've partly joined the group to see what we can do, because part of the problem we have is that because when you are a foreigner in a country or in a state like Texas, part of the reason why you try to stay and mind your own business is issues concerning status. So there are many of us who may not come in the open, but I thought this would be a good time to demystify that if you have an illness, even if you don't have status, you can still get medical care. And I would be willing to answer questions. I work mostly for veterans, but I think with the friendship I've developed here in Houston, which has many hospitals, including MD Anderson, St. Luke's, Baylor, we have Methodist and Harmon, I will be able to gladly answer any questions that can be presented in this forum.
Well, thank you, Dr. Kumenda. So we can come to Dr. John Kamau. You can move maybe the mic slightly, but otherwise, if you stay there, that would be fine too. We can see both of you. And then Jane will come next.
Thank you so much, Professor Kemper, for arranging such a meeting. I think it's well overdue and very timely, because as you can tell, maybe many Kenyans are not exposed to forums like this, and they have no way of expressing themselves, or maybe just giving their views on what's going on in this pandemic. We know this is a global challenge, but it is especially challenging for those in the diaspora, because you may find yourself lonely, you may find yourself away, you may find yourself isolated. And especially those in the diaspora without social support, it could be very challenging. And those who have been sick and those who have died, it has been a very challenging time. So for us to have a forum like this and thinking about it and putting it together, we want to thank you so much and just appreciate everybody who has spoken a word or two for this. Kemper and I work here, my wife and I work here in Ohio. The numbers here have not been very high, but those that we have come across have been very sick. And as you well know, this disease doesn't discriminate who you are. It doesn't matter whether you are the rich or the poor. It's affecting everybody across the globe and across the age span. So for us who are in the front line, a forum like this helps us to know what's going on elsewhere and how Kenyans are coping with this. not only in the healthcare service, but also in the financial aspects of this coronavirus. Could be that the financial burden will be bigger than the health aspect of it. And so for the diaspora people to come together and share their experiences and share what is going on, that could be very helpful. And if there is any way they can get help, either from within, maybe from the government of Kenya or our own government here, or from individuals, and you may not even get maybe financial support. Just a word of thank you might help. Maybe just a phone call, or maybe a question that you may have, or maybe a health challenge that you may have. You may just pick a phone and call one of us, and we may give you answers that you may not get wherever you are. So a forum like this helps bring people together and we want to be answered. So I'll be ready to answer any questions that might arise.
Yeah, Jen, you can introduce yourself since you are there, then we can come to Pam and start moving on.
Well, Jen Kamau here, and for me, I thank the Lord so much for all of us, and even first of all for protecting all of us. That's why we are here trying to see how one can help answer questions. Even when you meet somebody else who has similar question, one can be able to share. So just for the Lord protecting us so far, we just want to praise Him for that opportunity and the grace that He has given us. So I thank God for that. And just like my husband has said, even where I am, we haven't had so many of those cases, and we continue to take care of the patients, and so the grace the Lord has given us has just been very sufficient. So I'm grateful to be part of this meeting, to hear and know exactly what one can do, even to encourage somebody else who could be discouraged, or even somebody else who could be suffering from this disease and they are quarantined, they are in their house, and really they are just lonely there, just not knowing what to do. So having a forum like this one may help us. Somebody may suggest, may say there is so and so who is somewhere and they are quarantined in the house, and probably they don't even get a phone call from anyone, and this could be an opportunity to know who is that, and how can one lead to them and encourage them and hear what is happening to them and what they are doing about the disease. So thank God for this opportunity.
Well, thank you, Jen. Pam, introduce yourself, please.
Hello, hello. Thank you so much. I'm excited to be here too. As Professor Kefa has said, I am Dr. Pamela Obare Mogaka. I'm a doctor in nurse practitioner. I live here in Michigan. You know, Michigan has been one of the hot spots for this coronavirus, and we have a lot of patients in our, in our group that, in our practice that have been affected by coronavirus. But as the rest have said, I thank God I'm here. I thank God that we are still here, and God has been able to protect us from the coronavirus. Thank you, Professor Tiso, for having us, and we really appreciate. I appreciate everybody, Jen, Dr. Ngugi, and Dr. Kumenda. Thank you so much.
All right, we can start moving to the second session here. I'd like to encourage participants start making use of the chat area so you can start typing your questions, because we'll be coming there shortly. So the next place is maybe to go to the science of this disease. I don't think there is a whole lot we haven't had on TV already in terms of person-to-person dissemination, and issues of using social distancing to basically try to reduce the transmission of the disease, and wearing masks and those types of things. But I'm gonna come around starting with Dr. Kumenda. Anything that perhaps you can update us on in terms of the science and transmission? In a minute, we go around and then we come back to a different issue. And please, if you are not talking, mute yourself.
Needs to know. The thing that all of one of us needs to know is that this is a new virus that is zoonotic, that has come to infect humans. And because it's a new disease, there are few parameters which we normally use in disease describing a disease: the incidence of a disease, the prevalence of a disease, the infectivity rate, the case fatality rates. All these cases have not been brought to the conclusion because you find that you are missing your denominators. In any of the parameters that you want to do a calculation, you are missing the denominator because most of the people who are the target, who have been infected, who show clinical symptoms or signs, have not been evaluated. So in every case that you see, there is underreporting or there is erroneous calculations. So at this moment, I would caution everybody that most of the numbers you see around are actually relative numbers. This is a new disease. We do not know whether we are missing a large portion of the population, because 80% of the people who get infected do not necessarily go to see the doctor. They may have a little cold, they may have a cough. I have a patient who got infected and all they have is a headache. I have another patient who got infected. The only problem they had a sore throat. But the other patients who have presented with the complications, with the blood clots. So because of the degree with which this new virus is presenting, I would caution everybody to know that all the numbers we have may not truly reflect the potency for this illness. And that's why we'll all have to fall back to social distancing and trying to protect yourself. The problem there is when we are doing these measures is that we are delaying the possibility of us achieving a natural herd immunity. Okay. The only way we naturally, as doctors, the only way we try to create herd immunity is by marketing immunizations. But this virus also has a problem because of the nature of it is being a single-stranded RNA virus, and the nature in which it is presented is a challenge to those who are trying to make a vaccine. For those of us in the medical field who know what steps go into developing a vaccine, this virus is actually going to be a challenge. So because of all these, because we don't have a vaccine to help us with herd immunity, because it's only today that we have been so far informed that Redemsphere might overhope and reduce the number of days that you are sick from the virus. You see, this is an illness which doesn't really have a lot for the medical personnel to fight with. So unfortunately, we are trying to distance ourselves from the infection to give scientists enough time to come up with more information. And I spend a lot of time trying to tell my patients that what we are doing is delaying the inevitable, because we are all going to be infected. The problem is, it's a matter of when. And unfortunately, because of the way we all get access to the doctor, some of us who are from poor neighborhoods may get the disease and recover without even a doctor knowing. Therefore, your number may not even count. So I do not know how long it will take for us to really find a good picture of what this disease is. But it's going to take some time.
Yeah, thank you, Dr. Kumenda. Dr. Kamau, anything you want to add?
Just maybe a few points. You know, the COVID-19 is a new virus, but we have always had coronavirus.
Yeah.
Coronaviruses have always been with us. They cause about a third of the common cold. The coronavirus has been divided into various subtypes depending on the genetic makeup of the coronavirus. Like all of us know by now, they are called coronavirus because of the S spike that's protein on the surface of the virus. And they look like a crown. That's why they are called coronavirus. So there are many types. There's the alpha, the beta, the gamma, and the kappa, and others. They usually circulate around. This particular one mutated from one of the old coronaviruses.
Okay.
In 2002, we had SARS-1. severe acute respiratory syndrome 1. That virus circulated for about a year and a half, and then it died off a natural death. When this one came up, the Chinese people quickly did genotype. They genotyped it very quickly. And by December 31st, they had a full genotype. It was 96% similar to SARS-1, severe acute respiratory syndrome 1. And with a 96% similarity, they named it SARS-2 because they are very similar. They look alike. And this is the beta type of the coronavirus. Because of that similarity, the symptoms are also very, very similar. And because it was discovered, or it mutated in 2019, the World Health Organization then called it coronavirus 2019, giving it a name called COVID-19. And COVID now is the disease, but the cause of the disease is the SARS-2, SARS-2.
Okay.
Now, this new virus, we call it novel virus, not because it is acutely new, it's because it has mutated. Usually these viruses mutate within their natural environment. They affect animals and birds and others. In 2012, we had the Middle East respiratory syndrome. It's a coronavirus as well, very similar to this one. Now, this particular one, the Chinese want us to believe it came from a bat, and then it's in that sea market in China, in Wuhan province, it got into the pangolin, which is one of those reptiles that the Chinese eat. And then from the pangolin, then it affected humans. And then from that point going forward, it is now human-to-human transmission. This virus is serious because the infectivity is very much higher than the SARS-1. And now with the SARS-2, we are seeing that the infectivity is something we call R0. It's something close to R0 2.3, close to 3. In other words, if one person gets it, you infect 3 others. So the infectivity curve is much higher than the SARS-1. If you compare it with the normal seasonal flu, it is the seasonal flu has R1.1 or 1.2. In other words, if you have the seasonal flu, you only infect one more other person. And then the death rate is much higher. For SARS-2 or COVID-19, you're seeing a death rate of anywhere close to 5.5%, which is much higher. SARS-1 was even higher, was 10%.
Okay.
So we really don't know the direction this thing is going. If it follows the natural history, it will either die off or it will be here for a while. We have the seasonal flu that comes every year in a seasonal format. And this virus is being similar to all these other viruses. We only hope that it will not have the seasonal variability. But since it is still novel, we don't know the direction it's going. But one thing is for sure, it's going to be here for a while.
Okay.
Because now it's global and the infectivity is still going on, and it's much more serious than all the others.
Yeah, I think, Doc, you have managed to scare me more than I thought I was very comfortable. But you are right. We need to take precautions. So I want to bring in the two ladies, but switch the topic slightly towards why it seems to be affecting Black people quite a bit. So Pam, you'll go first, and then Jen, and then there's another science thing we'll bring up a little bit later on in terms of what the two doctors have already discussed. So Pam, this issue of infecting Black people more.
I think, thank you so much again for giving me the opportunity. I thank you, the two doctors. It's a lot of important information that we are learning every day. Mm-hmm. For me, I feel the reason why it's affecting Black people more than white people or other people of other race is because of most of the Black people have comorbidities. They have other diseases that are affecting them. Some of them have diabetes, some of them high blood pressure, Some of them are smokers. So this combination, already they have history with COPD. And as Dr. Komenda said, the disease affects the upper respiratory tract. So that means that these patients who are mostly Black, and because of their environment, because most of the Black people, poverty, they don't have insurance that they can go to the hospital to control their diabetes. They don't have enough money to buy medication. They are not informed about how they can maintain the disease which they have, or how they can manage the disease. That makes them be more vulnerable than the white people or the Caucasian people, as we say. The other reason, like for us in Michigan, why it was more prevalent and more deaths compared to other states is because there was so much misinformation. When this disease occurred in the beginning, most of the people believed that the disease was not affecting Black people. So Black people were still partying, Black people were still going around and doing things and going to gatherings, and they were getting infected and infecting and reinfecting each other. So I think that because of that, poverty, because of the comorbidities that they have, because of the lack of education about the disease, or lack of education on how to manage the diseases they already have, all this combination, I think it also costs the Black people to be affected more than the white people. And also the other thing I noticed is that most of the Black people don't even go to the hospital. They don't have that information that what can they do to prevent, like even to boost the immune system so that they can fight the disease. They really don't have the information. Thank you.
Excellent. So, Jane, do you want to add something to any of the topics we've covered? Science, the issue of Blacks being more vulnerable. Anything you wish to add?
Yeah, I could add a few things. Just say thank you again for this forum. One of the symptoms of the COVID-19 that really mimics the other symptoms, like when you have eaten maybe some food which was not well cooked, and then you start to feel some abdominal discomfort and have some diarrhea. And you probably one would think that maybe it's just the food that I ate. But lo and behold, we have seen in the hospital a patient come and somebody is complaining about his diarrhea, and probably you are treated and you are expected to be better. But then lo and behold, after some time, then you come back, the diarrhea is not even clearing, and you are tested, you start having even more symptoms, and then when you are tested, then you have this COVID-19. And this is one of the symptoms which is not being very pronounced, but now it's coming up quite much. And some patients are really having COVID-19, even with just diarrhea. And like the way Dr. from Texas said, some patients just say of headache, and that's all you have. So that is something that most people now we are learning, that even you can just have a simple diarrhea, and within no time you are diarrheaing more and more, and lo and behold, you have COVID-19. Wow. What Pam has said really she has actually really analyzed the number of the reasons why the African American or Black people are mainly affected. I mean, are the ones who are really being affected by this disease to a higher number. If we look at the way even other diseases are, like for example, cancer. If you look at the breast cancer, if you compare the Black people, compare this to the rest of the population, you see that the cancer is usually more reported, that the Black people are more affected, like cancer of the breast and the right. And simply because somebody doesn't go for, somebody may not have the know-how that they should be going for the regular checkup. So the same thing you can simulate it with this COVID-19. One may be unwell, but you are not going to see the doctor. You probably are used to waiting a little bit more. So by the time you are waiting, the disease continues to be more and more, and probably if you went earlier, you could get a little bit of the help. So far, we have that medicine that has been approved, and even if there was none, at least some of the supportive care that you could get before the disease gets too much. And of course, the crowding, most people because of the economic inequality, the crowdedness, people are more crowded, and the more crowded people are, the more the high, the possibility of passing the disease to your neighbor and to the family members who you are living with, and most people may probably be a number of people in the same house. And just to crown it off, most of almost agree with what Pam has said. A number of all the things she has said. So that's what I would add.
Yeah, which then brings up an interesting turn here, which is that we are all Black here, as far as I can tell. So based on these conditions that are affecting African Americans, so if I can do another round, but if I feel that the question has been answered, I can move on. So Dr. Kumenda, how vulnerable are Kenyan migrants given all these socioeconomic conditions? Are we at the same rate as the average African American, or are we better off, or should we be worried?
I'm going to answer that question, but allow me big bank on the prior question about why the Blacks seem to have had more effect. There is one cultural characteristic Blacks have that other people don't have. Okay. That is the characteristic of when a patient is sick, the people come to console the family, they come to visit them. I'm giving you a practical example of a relative I have in New Orleans. When their family members were sick, she tried to call all the others and tell them, so-and-so is sick, I've been told it may be COVID, please don't go to see them. They dismissed her. They went to see the relative who was sick. Out of those visitors who came, like she told me, maybe about 25 family members who went to see this matriarch of the family who was sick, about 14 of them ended up with COVID-19. I'm trying to say that we and the Black people from here, we are culturally similar. When I'm unwell, I expect the family to come, hug me, make for me soup, and etc. COVID-19 is going to be a game changer. When one of our family members is unwell, we still have to practice social distancing. Otherwise, you're going to have one family member sick, the rest of us will go to see the person, we will all be sick. It reminds me of that story of trying to get somebody from a hole. So the person is drowning, then you try to go, you drown, then somebody comes to see you drown. So we are going to drown a lot. Okay. Now, for most Kenyans, especially who are in Houston, fortunately, most of us really work. The bigger problem I have, and the biggest concern I have, is that we never get to know the immigration status of most people. And most people may not be able to realize that there is no relationship between illness and immigration status. You may be here with a poor immigration status, but when you are unwell, just go to the hospital and get help. That is going to be my concern. Okay. Majority of our Kenyans, especially in the part where I live, work, and many of them are in the healthcare field. We have so many pharmacists, we have so many nurses, we have other people who are the LVNs, we have other people who are working as CNAs, we have many people working in the healthcare field. And I know that if they do not do social distancing and use hand washing and all these other preventive kind of objectives, we are going to have many affected because many of us work in the medical field.
Excellent. So, Pam, do you want to add anything to the vulnerability? But it looks like it's more of an economic issue for us as diasporans then. Can you unmute? You are still...
Oh, okay. Yeah. Thank you so much, Dr. Kumenda. I think that I also concur with you because of our cultural background. It is more, we are more vulnerable to get the disease, and we are more vulnerable to be infected compared to other people. But I also think that one thing that is very, very important is, like, some of us who are in leadership, we need to keep educating our people. I can give a quick example because my brother was very sick in the house. He had COVID-19. He was here in the house. And for me, it was a great challenge to keep him, quarantined because he was staying in my basement. It actually took me to calling my brother back in Africa and saying that if he cannot keep staying in the basement, keep that distance, because I have children here, 4 children, have my old mom in the house, and for me to allow him to stay, and he was sick, he was very, very sick, he was coughing, he had all the symptoms, and he has a history of smoking before. He used to be a smoker. So he was more, like really, it was really very challenging for him. But because of the grace of God, we were able to contain it. He's now well, and we thank God. But through that, I learned that there are people who are not as strong as me, or who can be very strong and firm and say, you know what, you have to do. I was, if I tell you the truth, I was like behind him. If he did something I knew it was going to jeopardize anybody, I would quickly go behind, clean behind. If he touched anything, clean behind. I instructed my mom, she was not coming any close to him at all. And we were able to contain that with all of us in the same farm, in the same house. So I think that what Dr. Akumed has just said is that as Africans, we have that challenge of the culture of togetherness, the lovingness, the hugs and everything, but we have to change. This is a game changer. We have to educate our people to know that if they have somebody who is sick, there is no stigma about it, but education, knowledge about it, and how to keep social distancing, how to disinfect, all these are gonna help to decrease the infection rate. Thank you.
Yeah, I think that is a good point to start moving to something slightly different. But I was looking at the data on Kenyans in the US. I saw that 41.8% of us work in education services, healthcare, and social assistance. But I work in education. I know that the number of us in education is about 15%. So you can actually say about 1/3 of us work in healthcare. And that makes us vulnerable. But also, I wanted to go back to what all of you said a minute ago, and actually mentioned that I'm so glad we had the panel session, because whenever we hear of why Blacks are being affected most, we hear the negative aspect. I've never actually had this social explanation, Dr. Kumenda and Pam, you have actually brought up, and some of the other good points that we're hearing. This is actually why we need to be in charge of our own conversation, because otherwise you keep hearing we're bad people, we're whatever. I did not understand, even myself, I missed the basic connection here, which is that it's because we are fairly more social than everybody else, which then raises issues later on we'll say a few minutes about in terms of what is actually happening in Kenya then, because in Kenya it's the same thing, we're very social people. So if it gets in the population, it is going to be very difficult for us to be able to control it. So if I can move on a little bit, Dr. Kamau, I'm now coming to the question of testing. Notice that I'm cutting the conversation a little bit so we can cover as many things as possible. And panelists, if you think there's something you want to go back on, you can still mention it when I come to you. So the question of testing, should we all go out there and look for testing, or what would you advise? Because I'm told that tests are very much in short supply, Dr. Kamau. What do we do?
Yeah, the testing now has been structured here in the US far different from all other countries, maybe because of resources availability. Like in the hospital, there is a protocol that we have to follow.
Okay.
If you are completely asymptomatic and you want a test, we tell you no, you are not eligible. If you have mild symptoms that look like a cold and you're not sick, you're young and healthy, we say no, you should not be tested. If you're a healthcare worker and you develop symptoms, at that point, you get tested immediately, you are quarantined and kept away until you get better. And obviously, if you're very sick and you're elderly, you come to the hospital, we isolate you in an isolating room. We get you tested, and until you prove otherwise, you're kept isolated for the period of time you're in the hospital. Now, the testing that we have at the moment is called RT-PCR. In other words, reverse transcriptase polymerase chain reaction cells. That's what we have. At the moment, it's taking about 24-hour turnaround time. It's taking a little longer than we really want. The best test would be a point of care test where you know that test is positive or negative within minutes.
Okay.
At this point, we have antibody testing that will tell you within 5 minutes that you have had coronavirus, you've developed some antibodies, but that is a retrospective test. In other words, it just tells you you had a coronavirus some time ago, we don't know when, but you developed antibodies, you are now immune. But the test that we do to confirm whether or not you have the disease is still taking us about 24 hours or so. At least here in Ohio, I don't know about down Texas, but for outpatients, it's even worse. We give you the test and we tell you to come back in 48 hours. And for those who are just doing random testing, it's taking up to 7 days to get your results back. However, to come to your question whether all of us should be tested, I think for us to reopen the economy, it becomes an economic challenge, because if you want to go back to work, it's important to know whether or not you have had the disease and whether or not you're immune. For example, if somebody is going to operate a restaurant, you want to know whether those workers you have are all immune, so that when they are serving other people, they are not transmitting the disease. That is only possible with the antibody test. We don't have the resources right now. I'm sure the government is working hard, and from the report we are seeing, maybe over the next month or two, they will crack enough testing to do that. But that is way off. I don't think it's going to be possible for all the 350 million Americans to be tested. And even the confirmatory test is not a very sensitive test. In fact, when it was first developed in China, it was only between 30 and 70% effective. Right now, with some modification, it's a little, maybe 80, 90% effective. In other words, there is still a 15% chance that you will take that test and we will tell you it's negative, but it will be falsely negative. In other words, we may tell you you're negative, but you are still positive. So it is not a perfect test. So we still need to perfect our testing. But what we have is good enough for now. So that means that even the patients we are admitting in the hospital, we have sometimes to test twice. And it has been a practical challenge, because we do a test this week, the patient goes home, we tell them they are negative, and they come back to the hospital sick a week later. We do it again, and this time they are positive. They were positive all along. It's only that the test was false negative. So it's a challenge we have right now, and we are doing a few other confirmatory tests. For example, if we think you have COVID-19 and you're very sick, you're coughing, you're short of breath, you're having symptoms suggestive of COVID, we do a CT scan of the chest to see whether or not you've got a dose of particles and infiltrates that would suggest a viral pneumonia. And if your test is negative and the CT shows you might be positive, we isolate you and repeat the test and treat you as though you're COVID positive. So the fact that you take a test and it's negative, just bear in mind you still have a 15% chance that you are falsely negative. And it is probably not practical to test everybody. It's very expensive and probably not economically viable. However, in those very critical services where people must go back to work, I think it's crucial that there be mass testing to those specific people. For example, the meat processors. Now we are going to get short of meat because so many of them are getting sick. We need a test that can confirm that those who are actually processing our meat are negative, and those targeted societies or people should be tested. The rest of us, and especially the young and healthy, probably should not be tested. The very young are lucky at this point. Although they transmit disease, they don't seem to get very sick. And then we may have to isolate all the elderly people, especially among ourselves, until this wave is over. We don't know whether we'll get another wave in the fall, but for now we need to isolate.
Yeah. So there's another question I'm going to bring up, Jen, and I'll bring you up to that, but I want to set it up first by asking Dr. Kumenda to comment on whether we have good treatment options right now. But then I'd like you ladies to be thinking about, depending on how the treatment is going, what are some of the preventative and dietary things we can be thinking about? And I'm going to cycle back to you. So as Dr. Kumenda, should we have confidence in the treatments or not yet?
I'm going to answer the question on the treatment, but before I do, I wanted to echo what the doctor said and say that I want to say that all the labs that are trying to do the tests are doing their best. It's just that these labs have their limits of errors.
Okay.
The antigen test, for example, has a 10% error. Pretty much what it means is that if you came to my clinic and you have 10 people who have COVID-19, if I use the antigen test, which takes about 5 minutes, I'll miss 10%, which is 1. And in medicine, that's not acceptable.
Okay.
So nobody wants to miss 1, because when you miss 1 who had it, that's 1 too many. However, I have to say, out of frustration, FDA approved all the 120 companies that tried to get any testing to be able to do it. So we have so many tests. About 120 companies are doing all those tests to try and help. I also agree that the PCR, which takes more than 24 hours, is the standard. So even in Texas, the PCR is the one we use. The reverse polymerase chain reaction is the best. Now, as far as medication therapies is concerned, my number one recommendation would be that all those medications which the FDA and CDC were not recommending, I don't recommend them to any of my patients. I wouldn't recommend them to my family at all. Out of abundance of caution, Redempsia, which has been touted as one that could reduce the number of days COVID-19 patient is symptomatic by 4 or 7, is a good alternative. Remember, we have Tamiflu for flu. It reduces the duration of symptoms from 5 to 7 days. That can make a difference for somebody who is in a critical field, like maybe you are an anesthetist, or you are a pilot, or you are a teacher. You know, if you, instead of missing work for 21 days, because flu can take 21 days, you miss about 7, that's very good. That's really good. But the reason why we have been getting frustrated by the therapies is because by nature, the medical people don't like to claim there's a therapy when there is no, it hasn't been shown to be effective. So a little bit of this disease came and ambushed us. So there was a little bit more of policy pressure, political pressure, that really touched on the therapy for COVID-19 than any other illness that I know of. If I remind you, there was one time about 10 years ago when a gentleman who had multi-drug resistant tuberculosis escaped from Europe. He was in a flight from, I think, Europe to Seattle. I'll never forget that day, because there was a kind of like a team of people waiting in Seattle to receive him and receive all the the passengers who were on that plane, so that they would be quarantined, etc., and work on them. The way the medical community survives, usually when they have resources, is exactly like that. But for COVID-19, because we've been caught with our hands down, we've really been forced to do with whatever we thought can save life. And out of it, we have done things which may cause harm. For example, the issue of some of the COVID-19 patients producing or excessively producing cytokines, which lead to what we call a cytokine storm, can cause more damage. That's your body causing more harm to you. But the body, in its intention, it was trying to help you. But in trying to help you, it ended up overdoing it. A few of these patients who have been known to seriously progress from being normal one day to being dead after 2 or 3 days are cases of those who produce a cytokine storm. So there is varieties of presentations of COVID-19, making it a little difficult for me to say with some certainty that there is only one therapy that can be useful for any of the affected patients, making it possible for FDA to give physicians a leeway to use any of the medications they have on case-by-case studies. And to the best of my knowledge, only Redemsphere has been truly indicated, and it was a kind of like an expedited indication for use for this condition.
No, thank you. So, Jen, it looks like there's a lot of room for diet and the normal things we need to do to keep our immunity up. Can you please comment on those as we keep adding on what Dr. Komenda said? And then we'll go to Pam with the same question. But you can also comment on anything that if you think you wanted to say something about the previous, you can add quickly and then you go to the current one.
Yeah, definitely a well-balanced diet that keeps our body with good immunity.
Okay.
Because if you have a good immunity, when you're attacked by, just like any other disease, when you're attacked by the viruses, the body also has a way to try to clear the viruses. So a well-balanced diet and plenty of food is also important, just like any other disease where we have to fight with acid. And also there is something I would like to say, like us who are on the front line and now we are still working, for us who are working. I remember like at the place of work, what we have been doing, not necessarily diet-wise, but before you even sit on your desk, even though it's all clean already, we are still sanitizing our desk and the computer you are going to use, because you're not the only one who uses that computer. It's gonna be used by somebody else when you're not there. So when you report in the morning, the computer you are using, we are doing all the, wiping with our wipes, the wipes and cleaning even the phone that you are using, and every service that we are sitting on. That is also another way that we are using to prevent ourselves. And of course, the mask is another way that people are using to prevent ourselves, which of course has been talked about. We know that through the television industry that we have been updated on what to do. But I would say diet is really one of the things that will help, because once you have your body immunity is up, we hope that if one is to get this disease, you can be able to fight it, being healthy.
So I think what I'm hearing is sanitize, 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 and eat well.
Sanitize and exercise too.
Yeah.
Even exercise is important. Even at this time, the exercise helps the body to remain healthy. So
Okay.
that's why I'm good sleep.
Okay. So the usual stuff.
Yeah.
Yeah. So Pam, do you want to add anything there? Then we switch topics here in terms of, because I've seen you talk about diet a little bit. Maybe you can you unmute for a second?
So,
but it's good.
Excited. Thank you so much. Thank you so much, guys. You are doing an amazing job, Dr. Komenda. Thank you so much. Jane, thank you. For me, I think that as most of you know, and most of our listeners know, is that viruses are harder to treat than bacteria. So the biggest problem we have is like with the corona, that the virus, like I was studying about it and looking and saying, why is it this thing so harder to treat compared to even other viruses before? So they are saying that because it's an RNA virus, it means that if something has to treat it, it has to go inside the hollow, that thing, that like a capsule, go inside there and penetrate inside, which is very difficult to treat, penetrate inside and treat it, the virus. So that said, I think that delaying the infection is going to buy us time. Also, I also have to comment on what Jen has said, that for those people, or for some of us who are vulnerable, I think that I've talked about boosting your immune system, taking your vitamin C, making sure that you're eating healthy. Also, for those who are like smokers, stopping, or ceasing to smoke, doing those basics that can help your body in case you are attacked by this disease, to prevent yourself from going into complications and even death. The other thing that I also think that is that our people, especially our African people, education about the disease. Even if we don't know so much about it, whatever we know, we need to share so that we can, help our community. Dr. Kumena talked about Ridenavir, which was used, they used before for Ebola in West Africa. And that is why there's a scientist from France, they did a research on that. They were recommending that, they were recommending chloroquine, and they were also recommending with chloroquine and a CPAC, so that the people, they are calling that emergency. It was not recommended, especially for people of Seattle. They were using it as an emergency medicine to help, because it had been used before, and they were using it for these people, even if it was not recommended by FDA. So as we stand, what I would recommend is that prevention, boosting your immune system, cleaning, sanitizing, and just eating healthy, as Jen has said. Thank you.
Yeah, all right. So I think we have spent about an hour listening to the panel. I'd like to see if I can bring in the audience a little bit here. And of course, panelists, as you comment on these questions, feel free to put in anything that we may have missed. So one of the questions that came earliest is one that was asking, how do you, if you are living with a frontline worker, now in the case of Jen and Dr. Kamau, you are basically, as a couple, you're basically both on the front lines, So there's no way, I don't know, maybe let me direct that question to you. How do you live with a frontline worker? And what are some of the best practices so you don't bring the disease to the family? I know that Dr. Pam mentioned it a little bit, but you give us your perspective real quick, please.
Yeah, it's definitely challenging. For Jen and I, we just have to survive by God's grace. But people are doing various things, just like the panelists have said. Protection is the best way forward.
Yeah.
For most healthcare workers, you do the basic things that everybody's promoting. This disease is transmitted either by droplet or contact. And because of that, when you come from work, maybe when you get to your garage, you remove all the clothing you came with from the hospital and leave them there. You rush to the bathroom and take a shower. And that way you kind of wash all the quote-unquote viruses that you might have. Some people have gone to great extent of separating themselves from the family during this pandemic period. I know my boss is a funny guy. He took his family to the grandparents. So he's living alone. He comes, he takes a shower, takes the clothes away, and just lives alone because he has kids, and he took his wife and kids away. And for this season, the family is staying away with the grandparents, and he's staying alone. I think those are extreme measures. But I think if you can take the practical steps that everybody's taking, you should be fairly safe.
Okay.
The only thing is, don't be careless. If you are careful enough, you should be able to take care of it. But however, if you have elderly parents, those that are really in danger, they have multiple comorbidities, I think it would be wise for you as a healthcare worker to stay away and maybe separate yourself from those who are really, really vulnerable. Even us, we have determined we will not visit our daughter during this pandemic until it's over, because both of us are in contact with COVID patients on a daily basis. So we don't want to take the virus to her. So we just want to say, maybe just keeping away is a good idea. But both extremes are not good. I think we should also be human and continue living. Because if you take extreme measures, it will not be good for you, it will not be good for them. I think some common sense and good care will go a long way to helping reduce the transmission to your immediate family.
Okay. Jane, do you want to add something before I switch to another question here with Dr. Commander? Anything on that topic that John has commented on, Jane?
Yeah, actually, that's actually what is basically happening to most people. Even grad children, you don't want to go to the grad children. That's what even I know. I work with some people who have not even seen their grad child. For example, if you have, like, a grad child was born, but they haven't seen them, they have only been receiving the pictures of the grad children, and they miss them. They've been talking to the daughter over the Skype, but you know very well you're on the front line. You could go and see that grad child just as a normal regular time, but you know what you're doing to them. The best thing is to protect them. So all these things are happening, and with a better understanding that it is true they have been born, they are your grad child, or it is your sister's child, it is your cousin who has been born. There will be a time when you can really safely go and see them.
Yep.
So I think it's just a matter of really understanding that it's really for their own, for your own benefit, transmitting the disease to them. You may not be sick, but coming into contact with the patients on a daily basis, you carry a higher risk of even to a newborn child. Right. So even the newborn children, it's also good to realize that even if you have a friend who has a newborn child, there is no need to see them at this time if you really are on the front line. Okay. And there will be that's a nice time when you can go sit down and you feel they are safe. And you are not sick, but at least you want to protect others.
No, thank you. Those are good suggestions. Now I want to start reading some of the questions on the chat. Some of them are directed at particular panelists, others are general. So there is one here I want to send you away, Dr. Commander. There are 3 questions, so maybe you can write them down and answer them at the same time. I'll distribute them, and of course, if any of you other panelists think you can add something to the question I've already asked you, you can do that as well. Number 1, should we take comfort in having, this is actually coming from Lebanon Pande, should we take comfort in having a prior exposure to malaria and TB and the immunization we got while we were growing up in Kenya? So that's question number 1. Question number 2, does exposure and recovering from the virus diminish our organ functionality for the rest of our lives upon full recovery? I guess because it looks like the media is talking about people's lungs being seriously affected. So when I recover, have I actually recovered, or is it more trouble down the road? Number 3, we have heard of tests in West Africa, like in Senegal and elsewhere, which are costing $1 or less and quick results. Are they less accurate? So Doc, you can respond to those, and then I'll go to the next question.
Okay, can you hear me?
Yeah.
Okay, I will begin with the first question. If you have exposure to malaria and tuberculosis, and you have actually had infection with tuberculosis and you generated antibody, it means your immunity is intact, or your immunity generating potential is intact. That should be an advantage. The only problem here is, remember, we have said this virus tends to lead to what is known as a cytokine kind of storm. That means the presence of the virus invites your body to mount its defenses. In the process of the body making its defenses, it may overmake the defenses in the process of trying to fight the virus. That cytokine storm sometimes is the one that causes more damage. So if you have had tuberculosis, you have had malaria, your body can generate antibody. It still does not warn us or tell us whether you are going to be one on the group that can form a cytokine storm and therefore have a more severe kind of manifestation. All we can tell is that if you are capable of generating antibodies to malaria and tuberculosis, it is possible that with an intact immune system, you should be able to generate antibodies also to COVID-19.
Okay.
Exposure to COVID-19 and recovery, does it lead to damage of organs? This is an ongoing area of intense research. Those of you who have read papers could attest to the fact that in Korea, they found out, I think yesterday I read in the papers, that all those Koreans who were being informed that they had tested positive the second time, on a closer reevaluation of why they were positive, they found out that the positive RNA was from the RNA which was part of the lung damage. Let me explain in a simple way so that everybody understands. If you are infected with COVID-19, we look for your RNA, we do the PCR, we find you're positive, we say we are positive. We go on checking you after 10 days, we check it one day, we find it's negative. We tell you, you go home, you're okay. A week later, you come to the hospital for another reason, you have fever, we check it and we find that it's positive. In Korea, a large number of those who are done, they found out that actually the RNA they had was the extra RNA which was coming from damage to the lungs. So it was not really an infection. So there's ongoing studies right now to try and find out what type of damage there is. But I can tell you, if COVID-19 causes you to have a blood clot in your kidney is not likely to be happy for a very long time. If your COVID-19 makes you have a blood clot in your lungs and you develop a pulmonary emboli, depending on how many they are, if they are not large enough to kill you, you're still going to have some problem. So this is why intense clinical research is going on to see which will be the long-term effects. Now, as far as the test in West Africa, which I myself saw on, I think on BBC, about the $1 test, the history behind it is that in that area, the labs there had done extensive work during the Ebola time. They are primed to quickly transition from studying Ebola to any other new virus. The tests they are doing are antigen-based tests. There is a difference between the PCR tests, which we used as the gold standard, and the antigen tests they are doing. If you actually have a very good antigen test, it can be very cheap and you can do it very fast. Those are the tests being done in West Africa. What will bring their test to the world market is to see what is their positive rate. What I mean is, if you give them 100 patients who have COVID-19, is that $1 test going to pick all the 100, or is it going to pick only 90 or 85? And that I leave it to the researchers who are still working on it. I can tell anybody who is in America, if there was a test in West Africa which was $1 cost and it was very effective, it could have been in Houston long before we started this discussion.
All right. So Dr. Kamau, there's a question that was directed at you. So one is there are indications that the immunity from infections does not last long and that people can be reinfected. Can you comment on that? So that is number one. I want to give you another one real quick here. And I think it may have also come from the time Jane was talking about home remedies, but it says Dr. Ngugi, so I'm going to direct it at you and both of you can comment if you wish. The second one is, how about the home remedies like Mwarobaini, neem, ginger powder? Would you recommend people use that?
Well, you know, we live in the era of internet, and there is so much in the internet regarding what type of food to eat. And people are taking advantage. They are selling all sorts of quote unquote foods that would raise your immunity. All those things have not been proven. There was a huge study done by the American Medical Association regarding food supplements, I think 2 or 3 years ago. At that time, they put together all these food supplements that are on the shelves of big chains, and they found that none of them work. Literally none of them work, except vitamin D and vitamin E and one other one. But most of them don't work. In fact, they discourage practitioners from prescribing any of those. So we in the medical field no longer prescribe those quote unquote immune boosting medications or immune boosting foods because they don't work. Let me tell you what works. The natural God-made food. Don't buy vitamin C from the store. Go buy an orange and eat it. The vitamin C in the orange is far superior and far better than buying what has been synthesized, because we don't know whoever is making that vitamin. We don't know what they have done, the concentration. The FDA doesn't evaluate these things, so we really don't know. So all those things we are doing in the internet and selling, it's a billion-dollar industry. But majority of it scientifically does not work. So if you're hearing me, don't waste your time buying those immune boosting or helping or whatever from the internet or from the store. They simply don't work, at least from the medical point of it. They don't work. What works is the natural, good, full, nice, healthy diet. That works, and that will boost your immunity. Now, regarding immunity, this is a really novel virus. We've just had it since December, and now we are in May. We are just 5 months out. We really don't know whether the immunity you have developed will be long-lasting because this has only been a few months. Nevertheless, there are some tests that are being done and seeing whether or not the antibodies that people have developed can be packaged and be given to the other sick patients. But that immunotherapy is going on now. There is a study going on as we speak in Italy where they take the convalescent antibodies of people who have been sick, they have recovered, they have the antibodies, and they take their blood, they concentrate those antibodies, and they give it to the sick people. But that study is ongoing. It hasn't yielded good results as yet, but it's showing some promise. So we really don't have an answer regarding immunity. We don't know whether count fall, you will still be immune. We don't know. But going by the viruses that have been, for example, the SARS-1 and the MERS, the Middle East respiratory syndrome, it appears that that immunity did not last for a long time. So we don't know about COVID-19 yet.
All right. So there's another question here. I don't know who is going to take it. It says, can other antiviral analogs work? So that is a question from Eric. So can other antiviral analogs work? So you guys can write it, and then when I read another question, you can decide who is best placed to answer it.
Let me try and answer it.
Okay.
All these things are really ongoing right now.
Okay.
When first HIV came around, they started with one antiretroviral, and over the last 3 decades now, the antiretrovirals for HIV have really markedly improved to so good extent that literally you can live the rest of your life with highly active retroviral. I think the same thing will go on with the COVID. For now, there are so many medications that are under trial. Initially, the ritonavir, remdesivir, and lotonavir, they are all under under investigation right now. But the remdesivir has just been approved, and it's become the standard of care now. Everybody in the US will get remdesivir, I think, from starting right away. It has been approved by the FDA. But like Dr. Kimenda said, it is still too early. We don't even know whether it works. For example, the study I saw just showed that it is preventing people from dying from 8% for those who got the disease, who got the medicine, and compared to 11% on those who got the placebo. So you're talking about a 3% difference. So 3% difference, will it make a big difference in the long term? By the time we are through the next several months, we'll be able to get bigger numbers and we'll be able to tell whether or not it's really working. However, for now, I think it's just too early. Remember, like Dr. Kimenda said, really these retroviruses, what they do is they inhibit the reproduction of the virus. In other words, you are still producing the virus, only that it has been limited. It is too difficult for me to go to the science of it. But what happens is you get the medicine, the body is reproducing the RNA in your cell, and this medicine blocks an enzyme we call polymerase. It only blocks a few of those, but there are others still replicate. In other words, instead of you producing 1,000 viruses, you probably produce 50 viruses. So the viruses, your body is still producing them, but the medicine is trying to inhibit that production. So it's still too early. We don't have a cure. This will reduce the symptom days. It will prevent death from 8% to 11%, but it is still a cure. We have a long way to go. And being a virus, we really don't have a cure as yet. So we will use it as standard of care, and all the other antiretrovirals will be compared to this one. So this remdesivir will be the base at which we shall compare all the other new retroviruses that will be tested in the days to come.
So 2 more questions then, I don't know who best is, even though that the 2 doctors can handle it, but Pam and Jenny, if you want to jump in, let me know. There are 2 other questions here. If one develops a fever, can drinking tonic water with quinine help? So that is question number 1. Question number 2, I have had a flu shot. Do I have more chance to test positive for COVID-19? So those are the 2 I'd like to have addressed first. So who is best placed? Pam, are you able to answer it, or should we go to Commander? Who can?
Let me answer the flu one.
Okay.
Okay, go ahead.
Tested, if you are immune to the flu, the flu is a completely different virus from COVID-19.
Okay.
The influenza, there are several viruses. So you can have influenza A, influenza B, there is a H1N1, H2, N3, and H5. There are so many viruses. So you might be immune to one of those. Hopefully you are immune to influenza A or influenza B or whatever. So that's a different virus. So your body has to mount a new immunity to the COVID, because COVID is a completely different virus. So your body will have to mount that a new immune response.
So, Dr. Commander, were you going to add something? Pam, you were going to go for it. Okay, go ahead.
Yeah, I was going to add about why do we, first of all, I was going to comment on what, I think it was Dr. Komar who commented on the question somebody was asking about the analog medication. Some of these medications, as Dr. Kamau said, is that they are like I can't even pronounce it, but Redemavir. These are medications that have been used for other viruses before. So they are also trying to see if it can work on these viruses. So like the one that has been recommended, this has been used before, and that is why it was easy for it to be recommended. But what it is that every virus has its own uniqueness, that it has to be tested and retested so that the antiviral medication are going to work for this virus might not work for another virus. That is just the basic. As somebody was asking about why in Kenya we have low cases in Kenya compared to, you know, like USA. One thing, as I think it was again Professor Kefa, who said that the transmission vehicle was airlines, and mostly these airlines where people were commuting to big cities. If you compare our country, Kenya, we don't have a lot of traffic compared to places like New York, Chicago, or Michigan. The other thing is that testing, as if we here in the USA, we don't have enough kits. In Kenya, they barely have kits for testing. So really, we don't know if they are saying that this test, they have tested this enough people. So testing is not even available, or whatever they have is not enough to test everybody. And also, the other reason for the low cases is that most of the people are in the village. They barely move from the village. They barely travel. I think that also helps, and that is why right now they are recommending that people stay. They don't have to come to the big cities, because they know that where there's people are crowded, it's going to transmit quickly compared to the people in the village. For me, that is my reason why I think that the cases are not high compared to places like here in USA, where the cases, because we travel so quickly, we gather together, we can move. Somebody can be in 4 continents or 3 continents within 24 hours. And that person, will be, if they have COVID-19, will be spreading in the plane, in the people they meet. So it is faster to spread it compared to Kenya.
Okay, then I
want to,
okay,
I have a question.
If you have a question, please type it on the side, because we need to.
Okay.
Yeah.
Professor Tito, I wanted to answer the question on the person who said, can they use tonic water when they have fever?
Yeah.
I would encourage anybody, each and everybody listening to all of us here, including us who are doctors, when you have a headache, you try to look and see whether it was because the sun was hot, the room was hot. Try to think of what would it be. If actually you find you have been so stressed, sometimes if you drink water, it doesn't have to be tonic, and a few relaxation techniques, yoga, the headache can go away. If it doesn't go away, try to use Tylenol. I don't know why you chose the quinine, but I'll go for Tylenol. Now, because we are talking about COVID-19, then I have to link it to COVID-19 and then start saying, if you're one of those healthcare providers who is working in a place where you think you may have exposed yourself to COVID-19, please make sure you take the temperature so that at least you have a chance to tell your doctor, when I had the headache, my fever was 96 or something like that.
All right. So another question that has come up. So if you have a question, please, because we are many, type it on the side. It's easier for us to get them that way, just because Zoom begins to make too much noise for us. There are 2 questions here that are related. One is, what is the role of atmospheric temperature in relation to the spread of COVID-19? And a related question was, could you comment on the impact of the high environmental temperatures in Kenya on the transmission of COVID-19? So I think that's one of those things that the temperature might actually help to protect them. So who wants to go for that while I look for the other questions on the side?
Yeah, right now we really don't know about the effect on COVID and environmental temperatures. We do know that the southern hemisphere is enjoying a much better transmission rate compared to the northern hemisphere, and especially because of this winter time. However, this virus seems to be affecting everywhere all over the globe, even in areas that are extremely hot. Take, for example, The second case of death was reported in the Philippines. The first case was in China, then the second case was in the Philippines. And you know that Philippines, they are enjoying 90 degrees Fahrenheit. So I don't think the temperature will make a big difference. For example, if you go to Mombasa, Mombasa, the temperatures are very high and the humidity is very high, but still people are getting the virus. So I think the infectivity doesn't care about the environmental temperature. We hope that it will be like one of the seasonal common cold type viruses, but COVID-19 is proving to be a little different. So we don't know the nature of it, but we are now in May, June is here, and it will be very warm in July. We'll see how it goes. But it appears to us at this point, it doesn't matter whether it's in Australia, because Australians have very high temperatures right now, but still they have cases there. They are not as many as they are here, but still they are there. It appears to us what really matters is the vulnerability of the people who are getting it. If you are elderly and sick with multiple comorbidities, it doesn't matter where you are. If you get the virus, you're very sick.
Okay.
So I think that is what really matters. But regarding the temperatures, we don't know. But it appears like nobody is safe.
Yeah, then there is a quick question here. We're almost running through them. Then, you know, audience, please give us more questions. We're almost running out of them, although we may have to cycle back to the panel so that we can start concluding here. So I see, I don't know whether it's a suggestion or something any of you panelists can talk about, that somehow if you have lemon or orange peels and you add them to paracetamol and ginger and garlic, that can help a little bit. I think, Pam, you were, go ahead, Dr.
About it. The thing about lemons, oranges, they are high in vitamin C. And vitamin C usually works to boost your immune system. So, and also something like ginger, it is an anti-inflammatory. So I think when you take, like the way Dr. Ngugi said, you take a natural vitamin C, it is absorbed in your body better compared to the capsule or the one you buy from the store. So that is why, especially also in Africa, where the vitamin is there, the oranges are there. That is why we were encouraging people to take natural vitamin so that they could boost their immune system.
I would add, Dr. Tiso, that the mechanism of protection from the vitamin C versus blocking the COVID, we have to distinguish the two. COVID-19 is predominantly acquired through respiration. That's why we try to tell people, avoid touching the eyes, avoid touching your nose, avoid those two places. But if you swallowed the COVID-19 to your stomach, the acid in the stomach will take care of it. I've had this, many other doctors in another forum have that discussion. And the consensus is when you're taking the lemon, the vitamin C, the protective mechanism is through the boosting immunity rather than you being able to protect yourself from COVID-19 through the GI system.
I think a lot of people have talked about immunity today, and I think we probably need to add one or two things. The mechanism of body immunity is a very, very extensive, very detailed way, the way God created us. Now, it takes a long time to personally develop a good health system. It takes a long time for you to build your body. So if you are sick today and you take vitamins today, that may not help you. It takes a long time. It takes weeks to months and maybe years for you to develop a good immune system. For example, the diseases that are affecting most people are diabetes and hypertension and coronary artery disease and peripheral vascular disease. These diseases have something in common. They are all dietary diseases. Most of them can be reversed. If we can get into our diaspora people and tell them, if you have diabetes, especially the type 2 diabetes, there are two types of diabetes, there's type 1 and type 2. I'm talking about type 2. Type 1 is a completely different animal. That is a situation where you don't have insulin. But type 2 diabetes, you can reverse type 2 diabetes. You can control high blood pressure. And when you control those two, you will control all the other comorbidities that come with it, coronary artery disease, peripheral vascular disease, strokes, and all those others. If you do that, then you build your body immunity. And when your body immunity is good, alongside good diet and exercise, when viruses come, your body is ready to fight them off. But if your immunity is poor, your diet is poor, you're diabetic, hypertensive, when a virus comes around, your body does not have the capacity, or it has reduced capacity to fight natural infections. So for those of us in the diaspora, we should probably enjoy the good facilities we have, the education we have. And if some of us have an opportunity, we can tell people, how do you reverse type 2 diabetes? How do you take care of hypertension? How do you take care of this coronary artery disease and the others? Because if you take down those 3, 4, 5 diseases, literally, you improve your health by a big percent. And when these other things come, then your body is ready to fight off the natural immunity that you've already developed. But it takes work, it takes determination, but it is doable. And for those of us in the diaspora, we can do that because we have the ability to do it, we have the resources, we have the education, we have everything at our fingertips to reverse these diseases that are taking people down.
So there's another, we're getting towards the end here, so I want to hit on some questions here very quickly. There's one here that seems like it was addressed, Dr. Kamau, at the beginning, but any of you can take it. What is the accurate rate of testing tools for COVID-19? Could someone comment on the needs for continued isolation of negative tested individuals for several days or even weeks? And then, are there any mutations in the COVID-19 strand? Who wants to take care of that?
I can take care of the mutations for COVID-19.
Yeah.
COVID-19 is a positive single RNA virus. It requires your body to transcribe and make itself. Remdesivir, which is a nucleoside analog, manages to come in while the virus is attempting to make its baby copies. And once it enters the system, it manages to stop the virus reproduction right there. That reproductive hindering capacity of remdesivir is the reason why they are using it. However, viruses by nature tend to mutate. Right now, there are 3 strains of the virus COVID-19 that have been identified. There's A, B, and C. C is pretty much a baby of B because when you look at the areas where there is mutation, you can tell that the mutation from B resulted in C. There is a biochemical way you can know that the mutation C is a mutation from B. And A was the original one. Unfortunately, for most of us in America here, most of these researchers, and their work is not complete, find that much of the COVID-19 in America is more of the original from Wuhan. And that's why politically some people decided to call COVID-19 the Chinese virus or etc. I don't want to enter into that. But the virus really has its strengths and it has shown some tendency towards mutating.
Okay. So another quick question here, maybe 2, but there are like 2 left here. Then we start winding down because we need to talk a little bit about the way forward. I want to see if we can end exactly at 11, and we have already been going for a while. And also, before I forget, Dr. Kamau, we'll create more opportunities because there are some things you talked about, diabetes and high blood pressure that perhaps maybe we need a different session on, because some of that education is sorely needed. But going back to the questions, I'd taken a shingles shot. The latest part was in February. I was supposed to take a final shot in April, but when I called to schedule the final shot, I was told to wait until August because that may give me more chance of to get infected with corona. Can you tell me whether the pharmacist was right? So that is one question. Number two, following up on the analog, antiviral. In relation to HIV patients, will they have an advantage in some way since they are already on such medications?
I will start with the HIV one.
Okay.
The HIV people have.
Dr. Kamau, can you come a little bit to the, yeah, that's better, yeah.
Oh, thank you. Now, if you are HIV positive, your immunity is already compromised. So compromised is your immunity that anything small that like COVID-19 will probably take you down real quick. So like we said earlier, the antiretrovirals that work on HIV have not been proven to work on COVID. There are trials going on right now. Like ritonavir is an anti-HIV medicine that is being experimented on right now. So those trials are going on right now, but they have not proven effective as yet. So we really don't know. But because HIV patients' immunity is already compromised, and small or otherwise tend to affect them negatively and fairly quickly. So I don't think that will confer your immunity at all.
Okay.
Now, the other question was concerning varicella zoster. Like we said, these viruses are different.
Okay.
Varicella zoster is completely different. Thank God we have a vaccine for it. The delay by 2 months or even 3 months will not affect the effectiveness of the varicella zoster.
Okay.
It will still be effective even when you take it in August. They will not force you to start the series again. And especially if you took the series when you are young, you should be fine. Okay. So that should not cause anything. But it will not protect you from any other virus. Because like we said, these viruses are different viruses causing different diseases.
All right. So I'll ask one more question here, then we'll do a quick closing comments from the panelists. There's somebody asking, shed some light on BCG vaccine and COVID-19. So that's one question. Maybe they can be addressed together. The other one is more of a social question. I don't know whether the docs want to address it, but it's a question of asking whether this social isolation in Kenya looks like when people were taken into quarantine, they may have been actually exposed to COVID-19. It looks like that is a risk that some of them actually ran into. They left from the US, then you are put in a big isolation place, a quarantine thing. Is that exposing people more to the disease or not? Dr. Kumenda, you can go for it, and then Kamau, you can talk about it because we're going to go around fairly quickly anyway to close. Dr. Kumenda.
I wanted to say that in terms of BCG and COVID-19, BCG was a vaccination which we used to be given so that you can develop some antibodies to tuberculosis. But currently, it's not being done.
Okay.
I cannot overemphasize or stress what Dr. Kamau has been saying, that when you have one particular antibodies to one line of a bacteria, it does not confer any advantage to another line of bacteria or viruses. The only thing we can comment is that your body system has the integrity to generate antibodies, because there are many other people who are potentially incapable of mounting any antibodies. We say they are immunocompromised for whatever reason. There are very many cases where people are allergic. They cannot make antibodies. So when you are able to make antibodies, the only conclusion I can draw is that your body is intact. Therefore, if you are exposed to COVID-19, hopefully the same intact body will be able to mount a defense against COVID-19. I can't predict how your body will mount that defense to COVID-19.
Okay.
Now, in terms of the people who were rounded up and put in quarantine places, I have to say, I am so sorry for them, because a policy error made them stay together and may have inadvertently exposed them. I say may because I have no evidence. I say inadvertently because the intention for the people, the public health, was good. They say, you are the one coming from out there, you're the one who has been in London, you're the one who has been in New York, you are likely to have it. At the time they were landing at Jomo Kenyatta, I absolutely support what the ministry in Kenya was doing, get these people. What I don't support from there is how they did it. There could have been better ways to have those people quarantined in places where they would keep social distancing, because you cannot tell them you are going to quarantine, and while in the process of taking them to quarantine, you violate the social distancing rules, you don't give them sanitizers to use, and worst of all, you don't give them food. The stories I saw were a little bit way out of this world.
Yeah.
And I'm really so sorry. So their cases may not be classical cases where doctors want even to make comments.
Thank you. And so we're coming to the end. Let's start our round of conclusions here. So I'll go about the panel. So if there's anything that I did not give you a chance to say, that's the time to say it. But I'd like to start by thanking you for giving us a lot of useful information, a wealth of information we did not have. As we conclude, there's a question that came here. I think, Doc, somebody is thinking about your welfare. So this question, you can actually respond to it as you do your closing comments. Now that, doctors, you've spent time addressing us on COVID-19 and what we can do to stay safe, what are you doing in terms of your mental health stability? Because I think it's coming from the fact that you guys deal with a lot of issues all day long. So please, as you address that, also make your final comment in a minute, because we want to wind up. So, Dr. Commander, since you spoke, let's go to Dr. Kamau, and you can do it with Chen and then Pam, and then come back to Dr. Commander.
Yeah, thank you so much. Like every other stressful situation, those in the front line are bound to be stressful, depending on where you're working and the environment and your own personal issues, your family issues. There are so many things at play that cause stress. Work is only one of them. It's a component of the humanity that we find ourselves in. Personally, I'm a believer, and that makes the whole difference. I believe in Scripture. Scripture says, as a man thinketh, so is he. I don't believe in being distressed. I don't believe in being depressed, because the Scripture says if you keep your mind on the Lord, you will have perfect peace. So if you keep your mind in the Word of God and you think properly, you think positively, you're bound to have peace, and the mental issues will not arise. Truth be told, everybody knows that if you think positive, you end up being a positive person. If you think negative, you end up being negative. And COVID-19 may just expose what you already are. If you are a negative person, this small stressful situation may just expose who you are. So in terms of mental health, it is true, those in the front line are having to battle this COVID-19. And it can be very stressful, especially if you're working in a very stressful situation. I know colleagues who are really stressed out, and I look at them and pity them, because I know they don't have the peace I have. They don't have the joy that I have. They don't have the family I have. And they don't have the resources I have, and therefore they are stressed out. and you can tell who is at peace, who is happy, and who is not. The COVID-19 or any other stressful situation just brings up who you already are. People who are positive will always be positive, and they will always win. So I'm grateful that I'm not stressed out. I go to work as usual. I give thanks as I go in. I give thanks as I come out, and I'm at peace. After all, if you die, to be absent from the body is to be present with the Lord, and there is nothing better than that. So it depends on individuals, but I don't believe in being depressed. Depression is the state of mind. And if you think negative, if you think depression, you become depressed. And a good counselor will tell you or will try and help you to change your thought pattern from negative to positive. And anybody out there in the diaspora who is depressed, talk to some of us because we might be able to help you and maybe join us in this war against COVID in a positive way so that we all win at the end of the day. Because we don't want COVID-19 to come and then leave you with post-traumatic stress disorder or any other depressive symptoms or depression or whatever else. So I'm grateful that personally, I'm all right. I'm doing very well, and I will do well till the Lord Jesus comes. Now, regarding this forum, I'm very grateful that Professor Kefa, you put it together, and we hope we can do a few more in the days to come. Find areas that we can get help from other professionals, from advice from other people. I know many of our listeners have not had time to chat in and put in and talk, but maybe in the future they would have that opportunity to really express themselves and be able to be part of the conversation. But I'm very grateful. Thank you so much. And God bless.
All right. Jane, go ahead.
Yeah, I think I thank the Lord for everything, and I believe in surrender, bring everything to the Lord. And if I look at my life as a person, I don't think there is anything I control that which I cannot control, and I don't try to control it. So surrendering to the Lord and believing that the Lord is my protector and the Lord is our protector, I think that is one of the things that gives me strength, even when I go to take care of my patients. Because they are being, if I can protect myself to the best of my knowledge, then the Lord takes over from where I have left. So I believe in the morning, reading a scripture and praying to the Lord, asking the Lord to guide me for the day, because I know that is the only way I can continue talking to Him within the course of the day when I have an opportunity. So just like when we are all traveling back home, we are up there in the sky, we have no control of that plane. We are believing the pilot is doing what he has been trained to do. And we always believe that the Lord is going to take us safely back home and to and fro coming back this way. Same thing, surrender to the Lord and have the peace of the Lord. And remember, COVID-19 is here, it has come. It's just like any other diseases is there. Some people have gone because of COVID-19. Another one has gone because of something else. So let's not have COVID-19 bring a lot of pressure on us. Those who have probably high blood pressure start to shoot so high. Let's remember that the Lord is still on the throne. And regardless of whether COVID-19 is to stay for 2 or 3 months, we know that's where our hope is. Our hope is on the Lord and is not on the things of this world. So the important thing is to be prepared for whatever comes. We know we have the Savior who is there to be on our side at all times. So that then our hearts cannot be troubled, but we continue to believe in Him. So I thank God for all of us and all of the other participants who we didn't have them speak, and we know that the Lord is going to give us an opportunity and more opportunities to be together. Thank you all for everything, and thank you, Professor Kefa, for this opportunity.
Okay, Pam, can you unmute? Can you unmute?
You see, I always forget.
That's okay.
Thank you everybody for listening. I'm discovering this Zoom. I discovered a few things just later. thank you, the panelists, for the great job you've done. Dr. Kumenda, I saw you, I don't know, long time ago. Thank you so much. For my case, I would say that the way Jen and Kamau have said that if you don't, you have to believe in the higher power for you to survive through this, or even on a normal case. Honestly, life, other than COVID-19, there are so many challenges in life that can give people stress, depression. I don't allow anything to do with depression, stress to affect me, because as they said, that when you have somebody who is above you, when you have God, when you have, you know, that guidance, you don't have to worry about anything. The other thing I do is that I always teach my people, my followers, a gratitude journal. I have a gratitude journal. I write it every day in the morning or at night, things that I'm grateful for. So that when I try to complain, I look at the things that I'm grateful for and appreciate. I also recommend getting enough sleep, eating well, having your home as your sanctuary. My home is my sanctuary. I come home, I don't bring anything from the hospital. They don't even call me. I stay home, I enjoy my family. And I also recommend for every person who is here, take this time. If it is this time, if you are at home, you are not working, know that God created this time for you to spend with your family. Have something, create something out of this so that you can remember that during COVID-19, I wrote a book. During COVID-19, I was able to have a very, very close relationship with my children. I was able to have a close relationship with my husband. So I think that use this time to create a different positive memory for you and for your family. And I'm praying for all of you to stay safe. And I thank you so much for listening to us. Professor Kefa, thank you.
All right. Dr. Kumenda.
Thank you so much for giving me the opportunity and this platform to share with the fellow colleagues and other Kenyans. I want to summarize our discussion by saying Dr. Kamau wrote very important things which we all have to deal with. The issues which were never an issue when we were in Kenya, the issue of hypertension, diabetes, and cholesterol because of the lifestyle here. I would encourage you to find a forum, because in that forum, we're going to add a few things, include male-related conditions like prostate problems, and include other preventive conditions like cancer. I would encourage you to arrange such a forum because it will also be useful. The main reason why I'm trying to tell you this is I've had some friends say we have devoted too much time with COVID-19. A little bit of us is fear. I want to fight back and say it's not fear. It's just that the medical colleagues, the training we have is that we make a diagnosis, we treat. But right now we are making a diagnosis and we don't have the right tools to treat. So we get frustrated. And then when doctors are frustrated, the frustration becomes even personal. That's why you're seeing a little bit more of the medical dysfunction here. So I share the sentiments of the Kamaus that you have to find time to read your Bible, get yourself a good circle of friends who share with you. And when I leave work, I have friends who are not medical. So I really don't want to always be with medical friends. So I have many friends who are not doctors. We talk a lot more things. We talk about Safaricom, we talk about children, we talk about high school, we talk about so many things. So you don't really have to saturate yourself about COVID-19 and all the things which are there. Then the final thing is what Pam said, find time to relax, eat well, exercise when you can. But for me, there is always one thing that has brought me back to myself. Beyond thanking God for the gifts, the blessings that He has given us, when you are so comfortable, I'm always remembering the words of Luke 12:20. That man who was so comfortable that he said, I'm going to do everything, burn the granaries and be comfortable. And lo and behold, the Lord said, tonight your soul is recalled. So I try to say, let me not be so comfortable, because the Lord, lest the Lord say, tonight your soul is recalled. So I try to say, I pray that give me more time, more challenges. So when I do it, there is a reward that you get. And that is one reason why I'm saying, if you ever call on me to attend such a discussion or to educate or with Dr. Kamau, especially I like that issue of teaching our people about the new diseases which we found here, which we didn't have in Kenya, and which we don't have the resources to do a research so that we can say 50% of the Kenyans in the diaspora have hypertension, 40% have diabetes, 10% have, we don't have. But like Dr. Kamau said, we can educate them so that we can prevent, because prevention is better than a cure. So thank you so much, all of you, and those of you who listen to us. And where there may have been a little bit of technical glitches, we hope you can forgive us. Thank you.
Yeah, thank you, Dr. Kumenda. I think I want to, as we conclude, I echo one or two things very quickly. Dr. Kamau, as you say, this forum is actually full of professionals in many other areas. And it is the case that we're planning to organize a few more so that they can also be the ones teaching us, because we also want to take advantage of other people's expertise. Dr. Kumenda, in the room, we have Dr. Imelda Ongeri. She just got, I think, a grant of like $5 million to do diabetes work. So there's more work coming. Congratulations, Dr. Ongeri. And when we do that hypertension and diabetes forum, maybe she can actually participate as well. And I want to apologize if we did not have time for the rest of you to speak, but remember, this is the first of many that are coming. The other thing I wanted to mention briefly is that because of the mental health issue, like myself, what I've been trying to do is to look for the opportunities in COVID-19. There are many opportunities. Crisis has come to move some things out of the way and to create other things. For example, our burial culture would have taken 100 years to change, but it has been changed overnight. So like Pam was saying, look for opportunities to write books, you know, and since a lot of you that are here, I'm always challenging people. The reason Africa is where it is because every generation begins from zero. And the reason it begins from zero is because we don't write anything. All of you accomplished people, if you are not careful, people will basically summarize your life when you are dead. Oh, he was born in 1950, he got married in 1960, blah, blah, blah. And you are very accomplished people. You please write something that you can pass on to the next generation. Some of the stuff will be private, but some of this stuff needs to be public. You know, Dr. Kumenda, all that the kids want to know is how do I become Dr. Kumenda, which is actually something when I talk to kids in Kenyan schools, that's actually what they ask more. They don't ask me for money. They ask me, how did you become you? So let's challenge each other to write our stories. It can even be 50 pages, that is okay. So when you're thinking about opportunities in COVID-19, think of 3 words. You have 3 cycles. The first one is the cycle of control, the things that you control, which is actually what Dr. Kamau was talking about. That is where your power is. The next one is the cycle of influence, which is all of you here. I can say that you are kind of in my cycle of influence. If I don't know something, I can talk to Dr. Kamau. But there's cycle number 3, which is where most of us spend our time, which is cycle of concern. So we are all worried about COVID-19, cancer, and all these other diseases. But quite frankly, a lot of the things you are concerned about, you don't really have power to change. Your power is in the cycle of control and in the cycle of influence. If you cannot do it, somebody in your cycle of influence can help you to do it. If you focus on those 2, you should be okay. And then I also want to echo what the other speakers have said. Personally, I also like the Lord a lot, and there's a scripture I've been using a lot to remind myself to stay calm. 2 Timothy 1:7. For God has not given us the spirit of fear, but of power and of love and a sound mind. Social distancing is in the area of sound mind. Yeah. For example, so you don't get to ignore basic science like social distancing because you want God to protect you. That is putting God to a foolish test. You know, so there are things you should be able to do. So at least 2 Timothy 1:7, God has not given us a spirit of fear. So you have no business fearing, but you can be concerned without fearing. You can actually respond in faith. But he has given us a spirit of power. So we have power to do some things, a spirit of love, he loves us, and a spirit of a sound mind. I wanted to thank KESA, Kenya Scholars and Studies Association, for making the equipment available. You know, Zoom normally cuts out in 30 minutes, so this is a KESA conference, Kenya Studies Association facility. Cherono, the president. I see you, madam.
Yes.
I'm going to have you at least say hi in a second. And
Okay.
I wanted to thank everyone here in the audience. All of you, please stay safe. Before I bring up Cherono, there were questions that were raised here that we may not even actually have time to answer today. What is the next way forward? How do we use this information? People like Mutisha, you were raising those questions on the side chat. Those are questions that actually I think people like Inkesa and a number of other people would have to sit down and kind of think through. But we'll also invite you in the COVID-19 forum to actually contribute ideas on how do we go forward, other than the other panelists that we're going to be bringing on. Alex Inyawa from Boston, what did you want to say in a minute? Because we actually did.
Yeah, let me just have a minute. Alex Inyaga from Boston. Actually, we are in a hotspot, 62,000, 5,000 in my area. I know 5 Kenyans who are. Anyway, I was going to suggest, why don't we create a website that can unite the whole of United States? We can see each and every region, see what's happening in, and it can include in health, technology, business, and immigration. Immigration and immigration. Okay. And another thing that I was going to bring out is that why don't this panel bring up one time we meet in DC with all Kenyans, and then we can call the Homeland Security Secretary can address her, or somebody from the American that will see how the Indians did. Modi came here and they brought all the Indians together and they brought in Trump. We could do like that next year. We bring one so that they can recognize, we see we are in different business, we are in health, we are everywhere. I think that could do better. If we can mobilize through Kwitu or any other groups, that would be great. That was my suggestion.
All right, I wanted to mention in response to that very quickly that actually this forum began last week under the sponsorship of Ambassador David Gashiru of the Kenya Embassy. It was actually the first one to bring us together to talk about how we are dealing with COVID-19. Then we decided to actually make it permanent and address other issues. So, and there used to be a Kenya Diaspora conference at the embassy up to, I think, about 2014, 15, or around that time. And maybe there may be opportunity of bringing it back in the future, but we'll at least, under advisement, take the issue of the website. Last word, Cherono, do you want to say anything? Because we want to end.
Yes, thank you so much. I just want to thank Dr. Professor Otiso. I want to thank all the panelists, Dr. Kamande, Dr. Kamau, and Jane, Dr. Magak, Dr. Pam. It's been a wonderful, wonderful session. It was great to host you at CASA. So feel at home. I just forgot to show you where everything was, a restroom, and didn't give you any snacks. Next time. So we enjoyed. So I want to thank all of you. Actually, I was the one who was gatekeeping, monitoring, and getting people in, you know, with the logistics of Zoom. We have to keep doing that. We had 55 participants, so that was big. I want to thank the Kenyan Embassy. Somebody's still coming in. Okay, let me let them in. I want to thank the Kenyan Embassy. I want to thank the CASA Advisory Board and Executive Board members. I think we had about 5 of us who are here. I see Dr. Kimasov there, Dr. Ongeri is there. I see Pozotiso, Dr. Mutisia. I want to thank all of you for being here tonight to support. And as you said, we will continue to partner together. This is actually a conversation that we had with CASA, with Dr. Ongeri. I work with Dr. Ongeri very closely. That's my big sister there. So I want to thank you for everything that you do. We work very closely together on the issue of diabetes and all these other diseases. I'm the community engagement person. And we've been doing a lot of interventions, community pieces that we've done. You know, I don't want to share that right now, but I really want to thank you because like the Bible says in Isaiah 4:6, our people perish because of lack of knowledge. Personally, I've taken a lot of notes tonight. I do education forums on CAS FM, CAS TV. So I've taken a lot of notes tonight. I really appreciate all of you for taking time to do that. We had a lot of professionals. We had educators. I saw about 5 engineers in this forum tonight. From Allied Lilly, we had people from IBM, we had people from Commons. So we had a lot of different engineers and they do different things. And I just want to echo, my brother was here, he works with IBM and he's been very instrumental in designing some of the safety procedures there. So actually we saw a big diversity of students, professionals in healthcare, in the academy, engineers. So this was a great forum and I hope we can continue to maintain that. we as KESA will continue to partner together because we want to do monthly series. So this is really interesting and this has been great. I want to thank all of you. I just want to remind Dr. Kamau that you forgot one thing. I thought you were going to make an altar call. So I was like, okay, make an altar call, Dr. Kamau and Jane. So maybe
actually, I think that's perhaps where we can bring in Pastor Ismond to close us out. Pastor Ismond, if you can pray for us, maybe 1 second as we close.
Yeah, for sure. Thank you, everyone, and thank you for all the great information and all of us coming together. It's amazing that we're able to get together from different parts of this nation to inspire one another, but also to know that we are together, we stand together. I mean, I raised the question of mental health because it's one area that I've, as a pastor, I've, dealt with, especially having, professionals in our church that are in healthcare, and every single time they call. And one of the things that we have learned, as everybody has shared, is that we have to lean on the Lord. So even as we pray tonight, let's all believe that above all, we have to submit ourselves to the Lord. So let's get our thoughts together in prayer as we wind up. Let's pray together. God, we thank you for the opportunity that you have given us this night to call in and to listen to the great wisdom that you have given to those among us that you are privileged to be in the forefront, but also for many people that are really working hard to ensure that we stay safe and healthy and also connected as we learn about the current situation that we are in. Our prayer is that, Lord, you may order the steps that we have, and all those that are fighting the forefront to find a cure, to find a vaccine, that you may give them the wisdom. Thank you for the conveners of this meeting tonight, Dr. Otiso and everybody that's involved. We pray that you continue to be with them and give them the wisdom to bring us together. I pray for everyone on the line tonight that you remain safe with our families, but not only for those that are logged in, but even many more people that we represent in our different constituencies. As even we retire tonight, we surrender our lives to you. We pray that, Lord, we are nothing without you. But tonight we are confident that as long as we submit our lives to you, we are safe and we will be healthy. We commit everything to you, and as we plan to meet again, may you be with us. For in Jesus' name we pray. Amen. Amen.
Thank you, everybody.
Good
night.
Thank you.
Stay
God bless.
safe.
Have a good night.
We'll see you again. And please keep sending the ideas in terms of what you want to see in terms of future discussions. Thank you so much.